So good morning, everyone. Thanks for being on the call this morning. So as you can see, there are a few more of you on the call than there was on Wednesday. And that is because our in-person students and our online students are joining each other today for our speakers. So welcome, everyone. Before we get started, I'm going to just go over a couple reminders. So please make sure your full name is on your Zoom profile so I can count attendance. We welcome you to have your cameras on. It's always great for our speakers to be able to talk to faces instead of blank screens, please. Please be respectful, attentive of our speakers, staff, and fellow students. Rude language, bullying, or inappropriate behavior will not be tolerated. Please keep yourself muted when not speaking. If you'd like to speak, you can use the raise hand function and we'll call on you time permitting. And you can use the chat function to ask questions or answer questions during the presentation. So I'd like to welcome our first speaker. Dr. Natascha Tuznik is an infectious disease faculty associate clinical professor of medicine and program director for the Infectious Disease Fellowship at UC Davis. So welcome, Dr. Tuznik.
Hi, thank you, Sam, and good morning, everyone. Happy Friday. Delighted to be here today. I've gotten invited back to do these, and I so enjoy doing them. In years past, Sam, correct me if I'm wrong, I just kind of go over how I got to where I am today, and then I will try not to speak the whole time, so I allow for plenty of time for you all to ask questions. Hopefully, you will have them.
Yes, definitely.
Okay.
We want to hear all about you and then the specialty in particular and how they could get into it. But you have a very interesting story, so we want to hear about you first.
Yeah, sorry you have to listen to it yet again, Sam. All right. I guess putting myself in your all's shoes, which was a really long time ago, but that's neither here nor there. After high school, I went to college and I really had no idea what I was going to do. So I took way more courses than I needed to. I was just trying to sort of figure out where my heart lied. And for whatever reason, I really enjoyed sciences. And it's not like that anymore, but back when I went to undergrad, if you enjoyed science, you either went into research or typically headed in some sort of pre-med direction, whether that was for medical school, veterinary school, something along those lines. Again, it's very different today because the people that come through medical school are from all kinds of various backgrounds with different degrees. So I understand some of that's not applicable anymore, but nonetheless, that said, I gave medicine some more serious thought. I wasn't really sure, but eventually, long story short, I decided to start taking pre-med courses, which I just really enjoyed. Although I will tell you, when you go to medical school, they're really not very related at all, which I still find kind of humorous. Um, so anyhow, I did my pre-med courses and then I applied for an extra year to do some research at the Mayo Clinic because I thought, well, maybe I'd enjoy a career in some bench research, as we call it, where you're essentially doing lots of experiments and things like that behind the scenes. Um, Turns out I didn't love that as much as I hoped that I would. And then I thought I would try my hand at applying to medical school, honestly, not even really thinking that I would get in. And I did. And I went to medical school in Florida at Nova Southeastern University. And kind of in line with when I was an undergrad, I wasn't really sure what I wanted to be either. When I was going through medical school, I kind of enjoyed everything. And then along the way, I also decided to sign up for the military program. It's called the HPSP, or Health Professions Scholarship Program, that still exists. And I decided to choose the Air Force as my branch of service. And I'll allow us, we can talk about that more with questions later, but basically what you do is you sign up with the military, and then once you get into medical school, they essentially will pay for your medical school tuition, which is pretty expensive, as is anything anymore these days. And they also offer you a monthly stipend and they pay for all of your books. So that was really nice. But then afterwards, when you're done with medical school, you have to start paying back your time to the military. So again, we can talk about that a little bit more. But anyways, as I went through medical school and did my rotations, ultimately I decided that I loved internal medicine. And internal medicine is one of the branches of medicine. So after medical school, you do something called a residency, and that's where you are a doctor, but you're still in training, learning your specialty and working with physicians who have finished all of their training and have all of their board certifications and state licensures. And so there's, people will go into anything from surgery, orthopedic surgery, radiology, dermatology, family medicine, internal medicine, which typically revolves around working with adults in both the hospital and clinic settings. And then after I did my residency, I fell in love with the field of infectious diseases, which is a medical subspecialty. You may be familiar with infectious diseases post-pandemic. A lot of people didn't really know who we were or what we did until the pandemic rolled around. But just like there's any type of ology, so you may have heard of, heart doctor's a cardiologist and a kidney doctor's a nephrologist. These are all medical subspecialists who like really get into the weeds of whatever their specific organ or field is. So I do infectious diseases, which is the full body, but basically encompasses any and every type of infection that one could think of, or difficult to solve kind of medical cases. So that's what I do. So after I finished my residency, I got stationed at Lackland Air Force Base in San Antonio, Texas, which is now sort of morphed into this big conglomerate joint Army.
Oh, your audio cut out.
Can you hear me?
Yeah.
Okay, sorry. What was the last thing that everybody heard?
Texas.
Texas. Okay. So I got stationed in Texas, and that's where I started my quote unquote payback as a, full-fledged doctor, done with all of my training, and I was working with other medical students and residents. And in that time, while I was doing my payback, I was deployed twice. So there's pluses to doing the military route. Money, if you will, just sort of loosely stated, is a nice bonus to not have all of these loans that you have to pay back, into your 60s, which is what many physicians do. But there are some downsides, such as deploying and going, perhaps to locations you don't want to go to for long periods of time away from your family and friends. So one of my deployments was actually quite fun. I deployed on a hospital Navy ship called the Mercy. There's two hospital ships through the Navy. One is the Comfort that goes through South America, and the other is the Mercy that goes through the Asian Pacific Islands every even numbered year. So I got to deploy as an Air Force person on a Navy ship, which was completely unexpected, but ended up being a really cool experience. And again, that would have never happened had I not joined the military. And then my second deployment was not so fun. That was when in 2014, when we were still in Afghanistan. I deployed to Kandahar, Afghanistan, basically to a combat zone. And that was for 6 months away from my family, very limited communication, and basically being in danger every day. Not to sound dramatic, but I'm only putting it that way in the interest of time because those are all things I didn't really bargain for when I signed up for the military, but are, very real possibilities. But that said, I was fortunate enough to come back relatively unscathed, and I grew substantially in every way, shape, and form after that experience. And looking back, I wouldn't change it. I don't know if I would recommend it, but it was a lot of personal growth, made a lot of amazing friends, and it was definitely a time in my life that I will never forget. And so after that, I was about ready to get out of the military just because I had done all of my payback and happened to meet my husband, who's also now my husband, who's also in the Air Force and still is on active duty. And so after Texas, this was now, gosh, 8 years ago, he got stationed out at Travis Air Force Base in Fairfield. And so that's how we ended up here. And I eventually made my way to UC Davis. I've been here now for, I think, going on 7 years. and I primarily do hospital infectious diseases, but I also see some clinic patients, and then I spend a good amount of my time running the infectious diseases fellowship. So those are the internal medicine trainees that want to get certified and learn all about this subspecialty, which is another additional amount of years of training. Yeah, so that's what I do. I know I just threw a lot out at you, and in my mind, all of it makes sense. And if it was difficult to follow, I apologize. Um, but yeah, I've been talking for 10 minutes, so I'd really like to just give you all the opportunity to clarify anything that I said or ask any questions, about the things that I have done or do now. How did my job change during the pandemic? Wow. Gosh, that's a great question. It changed in a few ways. So first of all, I don't think most people go into a profession thinking that at some point in their career, they're going to be the end all be all for a lot of uncertain things. So what was very daunting about the pandemic was before we knew really anything about it, the public in particular, and our patients and our colleagues just sort of expected us to know everything and to get it right the first time. And so learning how to navigate yourself as a quote unquote expert and a specialist in something that really no one knew anything about, and how to handle, answers to things during media interviews, and trying to give the correct advice, but not making things up. So really navigating how to be an expert in an unknown situation. And I think all of us felt that way. Um, the other thing was that we thought was kind of cool is that, in the world of medicine and medical fields, we are, I don't want to say like a forgotten specialty, but because our name doesn't end in ologist, like cardiologist, pulmonologist, I think we should be called infectionologists, but we're not. We're called infectious diseases. The public really didn't know very much what we did, but now we love our field. We think it's super cool that the public kind of knows how we are helpful, what we do, and what kind of a public health service we can provide. So our jobs definitely changed. We were working insane amounts of hours, and we were happy to do it. But now that, things have settled, we're also grateful for that. But, it was another moment of really just coming together with colleagues for the greater good. And, not to sound cheesy, but when you go through medical school and you take your Hippocratic oath, I mean, that's kind of the goal. And so it was a very stressful but feel good time in our career field, but really stressful. So, okay, I see the chats kind of blowing up, which is cool. So, okay, second question from Leah. How many years are you required to serve after medical school? Thank you for your service. Thank you. That's very kind of you. So it depends. They offer different contracts now, anything as short as 2 years, maybe even one. I haven't looked in a while, up to 4 years. And so let's say you do 2 years. So they would pay for 2 years of your medical school, and you pay for the other two or get loans, and then you only pay back 2 years. In a 2-year payback, it's basically impossible that they would move you or deploy you. It's possible, but it's less likely. If you do more time, then you owe them that time back, but they pay for everything. So when I went to medical school, it wasn't as expensive. I want to say it was maybe $150,000 a year. And now it's insane. I mean, people are taking out $1 million loans to go to medical school. Um, so anyway, I did 4 years. I did the full 4 years, but I ended up staying in longer because of, additional training that I did and the deployments. And I was okay with that. That's not a must, but many of us end up spending more time in than we actually owe. Okay, next question. What was the hardest topic to learn for infectious diseases? Oh gosh. The hardest topic. Well, I already kind of spoke to the pandemic, an unknown thing. And I would say, we enjoy all of it. I think the hardest things are some of these neglected illnesses that we don't see much in our industrialized nation. So for example, if you think about a helminthic or a worm infection, like that's no big deal in America, or maybe, like kids get worms at school kind of thing, big deal. But in other countries, it disproportionately affects those from poorer situations, from unindustrialized nations, lower sanitary conditions. And we're talking an order of like 25 million patients. And, we don't think about things like that also means for them that some of their families are ousting them because they're ill and they don't know why. And the treatment is so simple and cheap, but they just don't have access to that kind of care. So those are both challenging because of how easy they are to treat and how disproportionately they affect other people. And they're easy to forget for us living in a place like this where we do have sanitation and better access to medical care. But it's definitely a global problem still with a lot of these diseases. Um, what does my day and work look like? Great question. So if I'm seeing patients, then I'm either seeing them in clinic or in the hospital doing consultations. So teams will call us on patients and say, hey, I have a patient with fever for 10 days. We've done all these things, they're not getting better. Please help us out. And then we go and evaluate the patient and try to help figure out why that might be. Or we have a patient who came back from Africa 3 weeks ago and is really sick. What are we not thinking about? Malaria and those types of things. So I'm either doing that or, like I said, I'm primarily working on our fellowship programs. So I work a lot with our trainees, making sure that they are getting the education that they need, that they're meeting all of their requirements to graduate, that they're doing well, that they're sleeping, that they're taking care of themselves, reworking schedules, running meetings, giving lectures. That takes an extraordinary amount of time as well. So probably a mix of patient care and that. What kinds of conditions do infectious disease specialists encounter in patients? Oh, everything. Absolutely everything. We The only thing like in the hospital that we don't see would be, for example, if I don't, if you all recall, but not that long ago, well, I guess it was now some years ago, but with the latest Ebola patients that they had in the US, you got to be on your toes for that kind of stuff because then you have to set up off-site areas with these different levels of containment. So, maybe you've seen a movie where you see somebody handling something infectious and they've got the whole hood on with the air system and they're getting decontamination showers. Like that stuff definitely does happen and we have to be prepared for it. It just would never be inside the hospital where others could be exposed to it. But back in, I think it was 2014, actually, with the last Ebola patients that were coming over, the department had to act fast and set up all of these types of stations outside of the hospital and do it safely. So you're always got to be on your toes because you just never know what's going to happen. Okay, how did practicing medicine differ in a military setting, differ from a traditional civilian setting? So also, well, all wonderful questions. Thank you. I would say a couple of things. So in the military, if you are active duty, you are required to get regular health care and basically be what we call fitness ready or flight ready. So if you're deploying, you got to be ready to go at any time. So I will say that people have access to healthcare and medications. So most people that you see who are active duty are in pretty good shape. We do see a lot of, quote, civilians. A lot of them are retired, active duty members. They have more chronic conditions that you then help manage. And then you also get exposure to, like I did when I deployed, I saw a lot of patients with just nothing, essentially. Leprosy, things that you may or may not have heard that are some people think about as, biblical things, but they still exist in the world. Or tuberculosis is everywhere, even in the United States, and some people just don't realize that. So you really get a very stark contrast when you do some travel or humanitarian civic service missions, deployments versus the military population itself. For example, the the members who are HIV positive, they're all on medications, they're all well controlled, which can be very different from what you might see in, resource poor area or just even a regular county hospital. How many years did infectious diseases take to specialize in? So, so you do your undergrad plus 4 years of medical school, and then you do a residency. Internal medicine residency is 3 years. Some residencies are longer. Surgeons usually go for 5 years. Orthopedics goes for 5. Neurosurgeons typically go for 7 to 9 years. But anyways, mine was 3, and then my infectious diseases subspecialty was an additional 2 years after that. Sometimes some of us do a third research year. It's not mandatory. Then, so most are 2 years, some are 3. I think cardiology typically is 3 years. But all in all, like I said, 4 years of med school, 3 years of that, 2 years of that, nine years basically, but 2 additional for the infectious diseases. What do I believe is the most rewarding part of the job, and on the contrary, is the most challenging part? The most rewarding part, so I feel incredibly fortunate because I picked a job that I love. I find now that I'm considered a middle-aged adult, which is crazy to me. I feel like I was all of you yesterday. It just goes by so fast. But you look around and there are so many people who are in jobs that they find unsatisfying or they don't love for various reasons. I love what I do. So I made the right decision, even though I doubted myself many times along the way. But I love it. And so that's quite simply one of the most rewarding parts of my job. I love being able to help figure out a quote unquote medical mystery. We don't.
Oh, your sound cut out again. Oh, not yet.
No?
Oh, there we go.
Okay. I think it might be my loose connection. I'll stop moving. Okay. Is this okay? All right. Um, So yeah, just especially when every once in a while, it's not always like, Dr. House. I don't know if you all are familiar with that show, but every once in a while you'll get one of these medical mysteries, and at the end of the day, it's almost always an infectious disease doctor who figures it out. Not always, but often, and so those are really cool. But the bottom line is helping the patients to get better. And the most challenging part I would say is that we spend a lot of time thinking about our patients and what to do. And in the world of medicine, that doesn't equate to money. And so I don't want you all to think that I'm complaining about money and we don't make enough money. But my point is, like, we're a very undervalued service in medicine, but we still do it because at the end of the day, it's what we love to do and we don't care. But so that the being undervalued part is not as big of a deal, but when a global pandemic hits and you're working 100 hours a week for years on end, um, that can burn you out a little bit. So that's, sometimes the difficult part of the job. Who knows if that will ever happen again in my lifetime? Um, we'll be ready for it either way. And yeah, I think I'm caught up on all of the questions.
Does anyone else have any other questions for Dr. Tuznik? All right.
Well, hopefully it was helpful.
Yeah, definitely. No, that was great. We haven't heard from anyone who had done the military service as part of medical, which I find fascinating because it's an avenue that people don't think about. And I wanted to know too, when you were traveling to these other countries for infectious disease, were you and when you went to Iraq, what kind of medicine were you doing when you were in Iraq?
In Afghanistan.
Oh, Afghanistan, sorry.
Yeah, that's okay. So, actually, thank you for bringing that up, Sam. If any of you do decide to do the military, you may need to be prepared to do a job that you're not at all trained for. So I actually ended up doing ICU, which is intensive care unit, critical care, um, 8 hours a day, every single day for 6 months without a break. There was 3 doctors there, and the three of us would take 8-hour shifts every single day, and this was what we did. And so I definitely have intensive care unit experience, but I didn't train in it. But there were surgeons there, so they did a majority of the hands-on types of things. And we did, a lot of the quote unquote internal medicine, managing medications and that type of thing. But I wasn't really doing infectious diseases per se. Um, so that, yeah, wasn't really prepared for that. And then there was actually one instance where we had a real mass casualty, and the surgeons were asking us to do procedures that we we didn't know how to do, didn't want to do, but it was again, not to be dramatic, but it was literally like, well, do this now or this patient is going to die on the table this moment. And so that's what I meant when I said it was an incredibly, I don't know what the right word is, a lot of growth during that time. But yeah, doing the military, you know, I would do it again. It's not for everyone, and that's fine. But it was experience I would have never had otherwise, and I do think it matured me a lot and made me appreciate things differently in life. Truly the little things. I came back and I was, you know, just felt incredibly grateful for everything. Not that I didn't before, but it was just entirely different. So I would still recommend it despite all the things that I went through. But again, it's not for everyone and that's fine, but it still is an option out there. And it's not just for doctors. If you are interested in being a veterinarian or a physician's assistant, or a nurse even, nursing programs, they have military, all the branches have programs for those things. So it's just something that you can consider, especially in this modern day where everything is so incredibly expensive.
Great. Well, thank you so much for being on the call. We really appreciate it. Everyone, say thank you to Dr. Tuznik, and I hope you have a wonderful rest of your morning. Thank you
Thanks,
again.
Sam. You too. Hopefully, I'll see
Thank
you
you.
again next year. And thank you all for joining on your Friday. I hope you have a wonderful summer and best of luck on your journeys.
All right, everyone. We're going to take a couple minutes of a break until our next speaker is on. So you can take the next 3 or 4 minutes, use the restroom, and we'll see you back here at 10:30. All right. Welcome back. So we're going to go on to our next speaker. So we're going to hear from Dr. Erin Kong. Dr. Kong is an anesthesiologist who has been practicing with TPMG or Kaiser Permanente for the past 19 years. She is currently serving as the physician leader, assistant physician in chief. This is her third year presenting to Future of Medicine. So welcome, Dr. Kong.
Sure. And thank you for having me, Sam, and the rest of SSVMS. Can you all hear me okay?
Yes.
Okay, perfect. Just wanted to congratulate you all for being here in your summertime. I think it's pretty fantastic that you're in this fantastic program. What a great opportunity to hear from different people in medicine. So please do take advantage of it. Know that not everybody has these opportunities. So as a quick introduction, again, my name is Dr. Kong. I'm an anesthesiologist. And if you've ever had surgery, you probably had an anesthesiologist, at least anesthesia for sure. And a lot of people actually forget about us, which is not a bad thing. It's somewhat intentional. So what I think I do is I'd like to go through my childhood and from my little timeline, go through high school, med school, and then kind of dive deeper into what anesthesia is and what anesthesiologists do. And I can talk about myself a little bit if there's time, take some questions from you. So childhood, my parents immigrated here, really from Asia to open up a restaurant. And that was their intent, to create a better life, typical immigrant story. There was no big pressure to become a physician. However, doing well in academics and athletics and whatever I was doing in school, there was an expectation that I was going to do it well if I was going to do it at all. So very somewhat typical. A lot of you are probably from very similar sort of backgrounds and expectations. And but honestly, as a high schooler, I was involved with various different things. Athletics, I did a lot of academics, I was involved with leadership. Personality-wise, I was quiet. I wasn't super social, but I would probably call myself a social introvert, meaning I enjoyed my close-knit group of small friends, maybe 5 or 6 of us always stick around together. And that was a sort of personality I had, which might fit into, where I landed ultimately as a career. When I left high school, I knew that I wanted to have a job eventually that was financially stable. So I was very practical in that way. But also I enjoyed the idea of helping people. So then fast forward, I leave high school, I go into college, I went to a liberal arts college, and I took many different sorts of studies. I took anthropology, Chinese literature, economics, and I did my sciences. And the beauty of the liberal arts college is you get to take a little bit of everything to kind of determine what kind of calls to you naturally. So I decided to major in economics. But I still decided to take my pre-med courses. So in order to go to medical school, you don't have to major in science. You could actually major in anything you want, as long as you fulfill the sub-core set of requirements. And around mid-college time, I actually knew at that time it was going to be either medicine or it was going to be Wall Street. I could have gone in two different ways because a major in economics is a little bit more business-like, analytical, and when I was thinking about lifestyle, it was going to be, am I going to be wearing scrubs for the rest of my life, or am I going to be wearing a suit for the rest of my life? And I actually thought at that time I could probably do either. When you kind of compare those two different, the fork in the road, both are potentially high stress. Medicine, there are some cons to medicine, which is you have a lot of potential disease exposure from the infectious disease perspective. And if we've all experienced this pandemic past 5 years ago, so you understand that. The cons of Wall Street also could be very stressful too. And for me, it didn't seem at that time it was necessarily very fulfilling. After a while, when you're just talking about profit, money, revenue, and you're cycling through that sort of thinking year in, year out. I did do some volunteer work when I was in college in the hospital, and that's when I started to realize that being a physician is probably the only way I wanted to go. It could be actually anywhere in healthcare. It could be a physician, nurse, physician assistant. There's a lot of different areas in healthcare. I really felt like after I did volunteer work, being in healthcare was a really great and honorable profession. One of the few that exists to where, maturity, experience are highly valued. And what I mean by that is, I'm actually currently nearing the peak of my game at my age, which I will not divulge, but those sitting in pro sports or those sitting in Silicon Valley actually might peak at age 35. But those in medicine, you can keep going and you're, close to retirement, you're at your peak. So it's always an honor and a privilege to take care of another human being. And I think that's the reason why that peak never really hits a plateau. So after I decided I was going to go into medicine, I applied early to medical school, got in, and I have to say medical school was a lot of fun. It really was. Probably the hardest thing about the whole process was getting into medical school. Once I was in, it was a lot of fun. There's a lot of a great group of people. I met my husband when I was in medical school. I was in a program. It was pass fail, so it was not as intense with letter grading, etc. When I was in medical school is 4 years. During that time, I rotated through different fields. I was torn between either OBGYN health and also anesthesia. And both were fantastic fields. Both were very cerebral, procedural based, surgical based. And when I did my rotation, I discovered that one had a little bit more control and one had a little bit less control. And I decided that I liked the one with a little bit more control better, which was anesthesia. When I say less control, I'm talking a little bit more about labor and delivery, delivering babies. That's a little bit less control. You just never know what's going to happen when a woman is in labor. And I actually discovered that I really enjoyed being in the operating room. If you have to enjoy being in the operating room, it's a critical factor for anesthesia and choosing the field. And what I saw was you give patients medication through an IV. It takes effect quickly. You don't have to wait for your next clinic visit to see if it worked. It works immediately, so you kind of get that immediate feedback. And I really did enjoy managing things like airways, putting in needles and blood vessels, and orchestrating a patient through what we call induction, which is going to sleep for surgery, maintenance, that's during surgery, and then emergence, which is how they wake up and how they wake up nice and comfortable. The beauty of anesthesia is that you only have one patient at a time, one procedure at a time, without the pressure of an office schedule where there's multiple patients potentially waiting or building up behind you. And anesthesia residency is, as you may also know, after 4 years of medical school, anesthesia residency is also 4 years. So what is anesthesia? It is a practice of medicine where we specialize in the use of drugs or other agents that cause the insensitivity to pain. So essentially you can do things to patients like have surgery. Patients won't feel it. Patients won't remember it. Patients might even forget what happened even before they were actually rolled into the operating room. Anesthesiologists are physicians. We're taking care of the heart, the lungs, the rest of whatever the patients need during the surgical procedure. You might view it as like we're the physician who takes care of everything for all specialties. We're a cardiologist, the pulmonologist, the GI doctor, we're the neurologist during the actual procedure. And we also are not only in the operating room, but sometimes we do help with pain management outside of the operating room for non-surgical scenarios. And those include things like giving patients who are in labor and having a baby an epidural, doing chronic and acute pain for patients who have pain syndromes with the use of different things like nerve blocks and catheters. Anesthesia is a very unique field because it's both cerebral and physical, but it's really not enough to just understand complex pharmacology. Pharmacology is another word for drugs, and determining the right dose. You have to know how to dilute the drug, you have to prepare the drug, you have to know the appropriate route for administration of that drug, which other drugs may or may not be compatible with the medication that you're giving, how to program infusion devices, etc. You have to be very, very good technically at things like finding veins. If you ever had your blood draw, that's called a phlebotomist. Anesthesiologists and nurses actually place IVs into veins. Sometimes you have to do that in the hand or the arm. Sometimes you even do it centrally in the neck, which leads directly to the heart. And honestly, the work for anesthesia becomes quite technical after a patient loses consciousness while they're sleeping, while they're having surgery. And that's, I would say, some people might say, well, that's a disadvantage, you kind of don't interact with the patient after they go to sleep. But I view that as, in a way, an advantage because it's pretty straightforward after a patient goes to sleep. They often say anesthesia is, 99% pretty steady state and 1% sheer terror. The 1% sheer terror is why we do all our training. I personally also enjoy anesthesia because once you do go to sleep, you have a very fast interaction with your patients. And I seldom need to be that physician who has to deliver really tough news of cancer or terrible news to patients and a family. In general, that would be more of the other fields or the primary physicians. There are many different fellowships that you can also specialize in anesthesia. Those include cardiac, pediatric, OB, regional anesthesiologists. They spend more time with awake patients. And I'll say that for intensive care and chronic pain specialists, they generally do see patients repeatedly over a lengthy course of treatment. So there's many different ways that you can actually decide to enter anesthesia. You can actually continue to branch out and make it more acute or make it more chronic. And there's many roles that you can actually play when you're an anesthesiologist in the perioperative world, including, staying and doing a pre-op clinic, running your ICU, and of course, leadership roles in the hospital are really, really important, so that there's a voice for a person who understands what's happening in the whole system. So what type of person personality might like to do anesthesia? If you are somebody who's a planner, an anticipator, a worrywart, if you're always kind of maybe worrying a little bit about what might go wrong, you might be a good anesthesiologist. We're constantly doing that in our daily work life and personal life. You have to be ready to diagnose heart or lung problems. That may complicate a surgery. And you have to decide which medications are appropriate. You also have to love pharmacology, which is medication and drugs. You have to love physiology, which is how the body works normally. And in terms of lifestyle, you have to be ready for early mornings and sometimes late evenings and even call. You have to enjoy the operating room. So I'm assuming many of you have not yet done a lot of shadowing in operating rooms, but you have an opportunity to shadow through a hospital and get into the operating room. You have to like that environment. It takes a little while to get used to it. But it is in general, the operating room and a hospital environment versus a clinic environment. And that's because anesthesiologists are typically in the hospital so they can handle other types of emergencies also. So what I'm saying by that is if you're like this sort of person who likes to have, a lot of rounding and consult constant references and have multiple meetings before you have to make a decision, then anesthesia might not be for you because there are times when you have to actually act very rapidly and make a decision where you're going to be right then and there going to decide we're going to go left or right and move forward and lead the team. When you're an anesthesiologist, you also have to enjoy the company of surgeons. Long gone, at least in my practice, is that stereotype of the malignant, abusive tradition of surgical training and surgeons. But sometimes you'll still see very, very high sense of confidence, even what I view as helpful arrogance with our surgeons. And you, as an anesthesiologist, you have to accept that in general, the surgeons are the captain of the ship. When crisis hits, though, anesthesia has to be ready to be the captain of the ship. Again, that's about 1% of the time. So you must be willing to deal with lots of different personalities with grace and even a little bit of humor because it's a long career. Or you will not be happy to coexist with various sorts of difficult personalities when that does show up. And you have to be okay when you're an anesthesiologist that you're not the person that the patient thinks of as his or her doctor. Often when you think of your own doctor, for many of you, you might be thinking about your pediatrician at this point, or maybe maybe some of you have an adult primary care physician, that's your doctor. When you need a procedure, say you broke a bone, you're going to think of your doctor as the orthopedic surgeon who's going to operate you and fix that bone. But in general, people don't think of their anesthesiologist as their doctor, and you have to be okay with that when you walk into this field. You have to be okay that somebody else is going to be the doctor, yet you are a physician. You have to be okay with kind of being that humble behind the scenes person who kind of sets the stage and brings a patient through safely. That everybody else is aware is super important, but the patient may not actually remember or thank you at the end. Your interactions with your patients are pretty intense, but they're short-lived. That still means that you have to have good people skills. They help a lot because you have to earn that trust in a very short period of time before they go in for surgery. And remember, most patients are super stressed during a really, really critical part in time of life where they're facing a procedure for various different reasons. And so you have to make sure the patient is comfortable with putting, honestly, his or her life in your hands after just a few minutes of meeting you. Often anesthesiologists are compared to pilots. So when the plane lands, nobody's clapping, they actually just expect, you to get to your destination. Everybody expects that. So nobody expects anything less than the perfect, uncomplicated anesthetic every single time. And I'll just have to say, as anesthesiologists, we do draw great personal satisfaction in what we do. one patient at a time. We put our patients and their families first, because we know that they depend on us to do our best. And that's why we wake up early, we get good sleep, pretty disciplined with that. And we have to make sure that we are taking good care of ourselves before we go into our work day. Not one of those yawn, wake up, go to work, yawn, and then look at the schedule. We're often prepared way before that so that we can take the best care of our patients. So what do? I actually work at Kaiser, mostly in Sacramento, the Morse Avenue facility. We have a lot of focus on high risk inpatient cases. There's a lot of neurosurgery at this hospital. We do a lot of complex spine procedures. We do cancers of all different kinds. I practice in a hospital setting. So in the hospital setting, it's nice because you know you have all the monitoring techniques, you have all your resuscitation drugs, you have blood products, bronchoscopes. There are some anesthesia practices out there that are a little bit more ambulatory, which is a little bit more like a standalone ambulatory surgical center, but you may not have as many of the hospital resources. So I like working in a hospital because I have those sort of resources available. The job in general can be stressful and tiring. Versus the outpatient day hour job. Anesthesiologists are needed 24 hours a day, 7 days a week, 365 days a year. So it's not clinic schedule. It's whenever patients are sick, they come into the hospital and you have to be ready for them. In my practice, I do work with nurse anesthetists and they're excellent. Nurse anesthetists also provide anesthesia. It's a different sort of training and we actually oversee their care as a team to take care of our patients. And then I just happen to be also a physician leader. I oversee many different departments. I personally enjoy mentoring other leaders within their departments and I do things like looking at budgets because actually medicine is a business and resources and how to grow and learn from some of our systems issues. So again, a typical clinical day, I set my alarm right around 5 a.m. I try to work out in the morning, 5:30. I arrive to work usually by 6:30 to 6:45, and we're seeing our patients by 7. So that's a typical day. Into the operating room by 7:45. I tell a lot of people we accomplish so much in one morning compared to the rest of the world that's kind of waking up at 8 o'clock in the morning. If you're a morning person, or if you can train yourself to be a morning person, then anesthesia can be a very good fit for you. You can, on your typical day, you can have one very long case or several short cases, but your day typically ends between 5 to 7 o'clock in the evening if you're not on call. And again, practices can vary depending on shift lengths and call schedules, a weekend, holiday calls, etc. And in addition to that, the case mix that's occurring at your hospital. I for instance, don't do OB/GYN or pediatrics. That's done at the Roosevelt Hospital. So eventually you'll find your little niche where you become an expert with high quantity of a certain type of case. So you can be really, really good at providing that expertise to your patients. So in closing, I think my advice, number one is just, you heard my story. Don't decide that you want to be an anesthesiologist today. That sounds silly to me. You should decide that you might want to serve people, that you might be interested in medicine, that you might want a fulfilling career. And in college around that time is where you actually ultimately make those decisions before you apply to medical school. And then in medical school, keep your options open. You heard my story. I was thinking about women's health. Or anesthesia, and the reality is I was actually even thinking about family medicine. So there's lots of time to decide because this is a long career that you're in. You want to make sure that you give yourself you're authentic to your own personality, so that you can choose the right specialty for you. And the most important thing I just want to let you know is don't think too much about money. Don't think too much about lifestyle. All of it is all fulfilling and worth it if you actually do end up doing the specialty that you love on an everyday basis. So don't let that be the #1 determining factor of which direction you go. Happy to take questions. I think I don't know if I have 30 minutes or it's something else, Sam, but happy to see if anybody has questions.
Yeah, we have a few minutes for questions. I did have one question. It came through to me. What do you do if someone starts to wake up during surgery?
Oh, great question. Well, in general, that's very rare. That's very rare. The couple of times you might, because anesthesia gives what's called a general anesthetic or a deep sedation, which that's why we go to school. We make sure the patient is not going to have acknowledgement of anything that's happening or even move during the procedure. In two types of procedures, that is cardiac surgery and or trauma, because the medications we give may sometimes depress the cardiac function, those are the two where you might have some what we call intra-op awareness. And for that, we do we're aware of that, so we do give medication that keeps them stable and takes away some of the memory. If, for instance, a patient does move in the middle of surgery, it does not mean that they remember that. They're just moving, it's a natural reflex, and then immediately everybody sees it, and we just have them go back to sleep very quickly. But waking up in the middle of surgery is pretty rare. Once in a while, you will hear stories from people saying, yes, I did wake up in the middle of and I'll let you know, it's typically a colonoscopy or some sort of GI procedure. And that's a different kind of anesthesia. That's light sedation that's given by procedural sedation nurses, where they can't go as deep with the anesthetic and with the medications that they give. So that is actually a potential expectation. Like you might hear noises and you might wake up a little, but in your mind, you won't care. You'll still be in twilight zone. And that's expected because not everybody needs to have a complete general anesthetic where they forget everything completely. They're still comfortable nurses.
Do anesthesiologists do the epidural?
Yes, they do.
Okay.
And yeah, when you're a woman's in labor, on myself, I have gone through that with both of my kids. You're an anesthesiologist or you're a nurse anesthetist. The first I had was a nurse anesthetist who quickly put it in. They're your best friend. I mean, you cannot have it like, even though I think I said I was a social introvert a little bit in high school, I made a lot of friends during my OB rotation. Something everybody just loved me because believe me, that pain relief cannot come fast enough. When your anesthesiologist walks into the room, everybody sighs and says, thank goodness you're here. So there's a little bit of heroism, especially in L&D, which is kind of nice.
All right, are there any other questions for Dr. Kong? That was a great overview and always one of my favorites to hear about because like you said, you're kind of in the background, you're so important, but not a lot of people, remember that that's such a part of it. And so you're doing your job if your patient wakes up and forgets you.
Right. I do have a question here. I think maybe it's private, and so I won't say the name, but the question is, I'll just read it out loud. Would you say you are skilled at math and require it often on the job? Also, how did you do with the cost of medical school? Yeah, so I was, although I went to a liberal arts college, I majored in economics. I was kind of a math person, probably more math than humanities through high school. I remember junior high, I did math counts, and during that time, I think, I was in the top 10 in the state or something. And I wouldn't say I loved it though. I knew how to do it. And yeah, you do convert things in your head. Remember, we're thinking about pharmacology dosing and looking at people's weights and converting constantly the right dosage for different patients. So there's math that you're using, but it's not calculus and it's not super fancy and complicated. After a while with training, you figure out how to do your math in your head with the training. This is the beauty of medicine. Medicine doesn't just pop you into like a room and say, hey, just go learn this. There's very formal training. There's formal didactics. They get you there. Medical schools, like I said, the hardest thing is getting in. Once you're in, then medical school wants to see you succeed, and we do succeed. The cost of medical school, for me personally, I went to my state school, so I'd have to say, please go to your state school if possible. Medical school is really expensive, and unfortunately, that is a problem with our healthcare system. It's so expensive sometimes that people have to take out huge loans if they can't afford it, especially in the private medical schools, that they end up choosing higher paying specialties in order to pay back their loans, which is tough. So kind of your lower paying specialties that are equally as deserving and fulfilling may not be chosen as much as some of the other ones because of the loan issues. So if possible, state schools are always a little bit cheaper in state school. I'm assuming many of us are from California here, so that's where you would aim for. They tend to be a little bit less costly. There are some schools out there that are now you start to see them, if you're admitted, the tuition's waived. Those are hard to get into. So even more reason to do really well in undergrad with your GPA and your level of interest. You have to show your demonstrated interest with doing some shadowing. All right.
We have a few other questions in the chat. Based on what factors do you measure the anesthesia?
Lots of different factors, but the first factor is patient weight. So the first thing I always look at is how much they weigh in kilograms. A lot of our different drugs have set dosing based on how much they weigh. So that's my most simplistic answer.
What is the most challenging aspect of being an anesthesiologist on a day-to-day basis?
Yeah, I think that's a good question. Depends on your role, and I think this is a personal opinion. So, is multitasking. I said during my talk that the beauty of anesthesia is you only take care of one patient at a time. But the reality is sometimes when you're working in a big team model, for instance, I work with a lot of nurse anesthetists, sometimes you do have to oversee 3 to 4 different operating rooms at the same time with multiple different patients in those operating rooms. So that ends up, we all think we can multitask, but the reality is we're not all that great at multitasking. So that is more challenging, especially if more than 1 or 2 of those operating rooms has something more acute and critical going on. You have to be able to make those decisions about what's gonna happen for each of those rooms quickly. And it's not only for one patient, you're probably maybe doing 3 or 4 at the same time. So the multitasking piece of the job description that I sometimes have to do is probably the most challenging part.
All right, we have one more question. Have you ever had any other type of medical emergency during surgery? If so, how did you handle it?
Yeah, the biggest sort of medical emergencies are patients who are not going to make it, right? They come to your operating room table, you put them to sleep, and you're doing CPR on them. I've had patients die on my table. You handle it with grace. It is tough. You realize that the team is going through present trauma when that happens. Nobody wants to see that ever happen. You realize that the patient's family, usually when that happens, the patient's very sick coming to you. So it's kind of like a last ditch effort to try to save the patient. So having conversations afterwards with patients' families, etc. Just being human is a big part of this job. So despite the fact that I say, we get to put our patients to sleep and then we wake them up and our patients typically don't remember who we are. When it's really critical like that, we're all physicians, all healthcare workers in the room are there to take care of the patient and their family. So there is a huge human factor that goes into how you handle that, and handling it with, grace, giving yourself grace, and ensuring that the team is okay while we walk it through the next process with the families. Probably, it's a tough thing to handle, but it actually reminds you why, in a way, it's a gift to do what we do because nobody else does that.
All right. Well, thank you so much for joining us. Everyone say thank you to Dr. Kong. We really appreciate you being on the call and sharing your story with us.
You're all welcome.
So have a great rest of your morning. And for all of you, take a couple minute break and then be back here at like 11:05. Thank you.
Bye.
All right. Welcome back, everyone. So our last speakers for the day are going to talk a little bit about occupational and physical therapy. So Jessica Kager is an occupational therapist from Shriners Hospital, and Jeremy Yee is the senior physical therapist also at Shriners Hospital. So welcome, Drs. Kager and Yee.
Yeah, so I'll just introduce myself real quick. I started at Shriners about 6 years ago now. I've been a physical therapist here, and a little bit about Shriners. We do treat a variety of patients. We treat patients from a burn injury. We're a specialty hospital in burns. We treat kids on the outpatient service after an orthopedic surgery. And then we have a wide variety of patients with traumatic or non-traumatic brain injuries, spinal cord injuries, and then all sorts of other random diagnoses we see too. But well, it's great that we get to see a variety of different types of patients, and anywhere from infancy to up to age 21.
So my name is Jessica Kager. If you kind of missed it earlier. So I'm an occupational therapist here. I've been an occupational therapist with the Shriner system for 5 years as well. I've done kind of a lot with OT between working in pediatrics, adults, and even in an inpatient skilled nursing facility. So I think occupational therapy is a pretty wide scope of practice. It's great here at Shriners because you're able to practice to that scope's full potential. Kind of to reiterate what Jeremy said, is we see kids from all walks of life, all different type of diagnoses. And I think the best part about working as an OT is really honestly being able to collaborate with your team, whether it's PT, speech, the doctors. OT is, in a nutshell, kind of working on what that client or patient is not able to do after injury or illness. And the OT aspect of that would be either adapting their environment or teaching the kid new techniques, and for them to either do their bathing, dressing, ADLs, so activities of daily living, or return to a previous activity that they weren't able to do after the injury.
And then going back to physical therapy on the flip side, our overall scope is to focus on the gross mobility aspect of rehabilitation. We're thinking about being able to transfer out of bed, stand, walk, or use a wheelchair if someone is having a more difficult time walking, or if that's not a realistic goal for them, or teaching a parent how to safely position and transfer their kid. Those are kind of the bigger scopes of focus that we work on, but there is a lot of overlap with occupational therapy. And the really cool thing about Shriners is that we get to co-treat a lot, whether it's inpatient or outpatient. We get to work together and collaborate on goals and really figuring out what the patient and family need to be able to safely discharge home or get back to what their personal goals are.
Can you answer what is the schooling path? So what degrees do you have to get, and what kind of licenses do you get?
Yeah.
So for OT is kind of in a transitional period where you either need a master's or a doctorate. I think within a couple years, all the master's programs to be an evaluating occupational therapist are going to eventually phase out. So it would be a doctorate program. And within those programs, you need to have a bachelor's and the prereqs to apply. So I actually have a bachelor's in English with a minor in psychology. So it took me a little while to find OT and decide that was the route that I wanted to pursue. And so after that, so it's 4 years of undergrad to 5 years, depending on what your life kind of looks like at that time, and then applying either to a master's program or a doctorate program. I kind of also did a little bit longer route where I did the master's program, which took me 2 years. And then during that time, the OTD started coming out for a post-professional. And so I then went back to school and pursued that while I was working full-time at Shriners. So there's a little bit of different routes to get to there. We also have occupational therapy assistants, which is an associate's program that will work alongside the evaluating occupational therapists. I'll turn it over to Jeremy.
And then for physical therapy, it's kind of similar. First of all, you need to get your bachelor's degree. Kind of like what Jessica said, you don't really have to specialize in a science background. You could have a major in English, but you will have to complete the prerequisite requirements in order to apply for the graduate school programs. My undergrad degree was in exercise biology at UC Davis, but it could be any 4-year or longer university to get your bachelor's degree. And then in order to get your physical therapy license, you will have to go, pretty much all schools are now a doctorate program. Most of them are 3 years. So after that 4+ years of undergrad, you'll have another 3-ish years for your physical therapy schooling. There are some programs here in California that have a accelerated 2 to 2.5 year program. And then once you graduate from physical therapy school, you can practice as a general physical therapist, whether it's in the acute setting, outpatient, inpatient. You can specialize, and sometimes people do go into residencies or get specialty certifications, and that is optional. And then similar to what Jessica was saying about occupational therapy assistants, there are physical therapy assistant programs too, which to be a licensed PT assistant, you have to get your associate's degree in that field. But that would be just after high school, or there's no requirement before applying to PTA's schools.
I saw a question by Sam Mello. I think that's actually a really good question. And it's going to vary dependent on the school, whether it's a state school or whether it's a private school. It's also going to vary state by state, depending on what location you are in the country and which schools you've gotten accepted to. And I graduated with my master's in 2017. So I think, I'll be honest, I think a lot of the tuition numbers that I saw back then are probably like a little outdated now. But back in 2017, when I was applying, there's different scholarships to assist with that tuition. But if you're looking solely at an occupational therapy program, when I applied to 6 different schools, to just kind of give you an idea of the numbers I was looking at, it was ranging from $25,000 for a program all the way up to $130,000 for a program. And these were programs, I'll be honest, from Oregon to Ohio State, from U of P to University of Texas Medical Branch to Texas Women's to University of New Mexico. So I think my advice in terms of like tuition and thinking about that long term is really just to apply to a variety of schools and then kind of know what the best fit is for you and your lifestyle afterwards, and getting your acceptance letters, because it's going to vary in terms of tuition costs, and then housing if you start factoring in all those other things as well.
Yeah, I echo everything that Jessica said. Basically, for physical therapy schools, and I graduated from my PT program in San Francisco in 2019. On average, at that time, tuition costs would have been maybe around $30,000 for like a state school per year. And if you multiply that by 3 years, just tuition alone might be almost $100,000. For San Francisco at that time, it was closer to $40,000 a year. ended up being about 120,000 for the entire program. But again, those numbers probably have changed, and there is a difference between the public or state schools versus the private schools. Yeah, and then factoring in cost of living, living somewhere like San Francisco might be a little bit more than here in Sacramento or a lot of other locations. So taking into consideration what you're able to do in terms of loans and financial services is really important.
I think we got some other good questions on here, Jeremy.
Yeah.
Let's see, we're gonna scroll a little bit and try and answer everyone's questions.
So we'll start with Kennedy's question. What do you do in the case that the patient doesn't improve during therapy? What is the next step? So we have to be really honest with ourselves. We, as a clinician, my hope is to be able to treat every single patient and provide my services to everyone I can, but it's not realistic. There are some patients where they're not progressing towards their goals and they plateau, or maybe they could benefit from being outside of the hospital or just focusing on other services. So having that conversation and being honest with patients and families, if PT is appropriate to continue or not, and then also talking to the other team members. Jessica and I work really closely in our inpatient rehab unit, so we have access to the doctors, care management team, nursing, a neuropsychologist. There's a lot of team players involved. And if we're thinking about like discharging a patient and from the hospital back to their home, if they're not really making much more progress, then we also do have to talk to the other team members and make our realistic recommendations. And sometimes those are difficult conversations, but they are needed to be had.
And a lot of times too, it really like makes you look at yourself as a clinician, because like Jeremy said, you want everyone to improve, but also depending on your setting as well, like if you're in an outpatient setting, for example, and someone's not improving, you might start asking some other questions, like, are you doing your exercises? Are you doing your home exercise program at home? Because sometimes those exercises at home are really what's going to propel that patient to the next step. It's kind of like, you know, if you eat ice cream Monday through Saturday and you only eat like one healthy meal on Sundays, you kind of have to start making sure you build on that healthy meal throughout the week to see the lasting effects. So like Jeremy said, you just have to have that conversation sometimes with either like the caregiver or the patient, and just ask them to be truthful, see if there's anything you could do to help like put it more into their routine or their habits. That way they can adhere to the home exercise program, and then go from there. Or maybe they just need a therapy break. Maybe they're burnt out. They need to take a step away from therapy and then come back in a month maybe, or sometimes there's other factors in their life that you might not be aware about as a therapist that's kind of impacting that progress as well.
Great question. And then how did you realize you wanted to do this for a job? Let me start. Okay. Well, I started when I was in undergrad at UC Davis. I wasn't sure what my major was going to be. I thought I was interested in nutrition. My family wanted me to go into medicine or healthcare in some aspect. So that was always something I was thinking about. I really loved animals. I was interested in becoming a veterinarian at the time too. So when it came to deciding a major, I was able to think like really hard, and over the summer before starting undergrad, I saw the list of majors and I thought that exercise biology sounded really cool. So I went with that. But after my first year in undergrad, I did look into volunteering in different fields. At Davis, there were a few different internship and career opportunities to volunteer with. So I explored that, and I was able to get an internship at an inpatient physical therapy location at the UC Davis Hospital, UC Davis Medical Center. And then volunteered there. I also did an internship with the nursing staff at UC Davis. I did a separate one at a chiropractic outpatient clinic. So I kind of got my feet wet in a few different healthcare career options. And then I also went back to UC Davis and had another physical therapy volunteer position. And they hired me on as a PT aide at the time. So I had a lot of different opportunities, tried to figure out what I wanted. And then ultimately, I really enjoyed the physical therapy aspect of being able to spend so much time with our patients one-on-one, whether it's 45 minutes at a time, an hour, and really being able to build rapport and track progress and be able to meet the patient's goals and be a really big part of their recovery. At first, I thought I was going to go into more of in pediatric sports. And then when I got hired eventually at Shriners, I am now doing more neurology, the neuro rehab of brain injury and spinal cord injury. So there's so many different options in physical therapy. And I just really enjoyed being a part of that rehab process and making a difference in someone's life.
OT, I don't know if I found OT or OT found me. It took me a really long time to even know what OT was because no one really talks about OT. People talk about PT a lot, but I knew I didn't really want to be a PT. And so in undergrad, I think I did probably every major under the sun. I did 2 years of prereqs for nursing. I also thought maybe I wanted to go to med school. I also did a semester for finance and marketing and business administration. I did another semester where I thought I wanted to be a teacher. So I really bounced everywhere in undergrad. I did a semester of independent study. I think it got to the point, I thought I was going to be a psychologist, a sports psychologist. So I did a lot of graduate courses in sports psychology. And then one day, one of my best friends in undergrad was like, hey, like, let's write down what we want to do with our lives. Like, we're both at this point where like, we need to graduate. We're coming up on passing 4 years and neither of us knew what we wanted to do. So we wrote down everything we wanted in a career. I wanted it to be in healthcare. I wanted to help people. I wanted to not be at a computer all day. And I wanted it to be something where I got to make an impact on people's lives. And she was like, you sound like my mom. She's like, my mom's a hand therapist. And I was like, whoa, like, what is a hand therapist? She's like, well, it's an occupational therapist. And I was like, okay, I know there's occupational therapists in the school setting, but I didn't really even know what an occupational therapist was at that time or what it entailed. But I think that conversation with her is really how I found out what OT was. And then I drove out to Utah one summer and I did an internship at Intermountain Park City with her mom. And then from that moment forward, I was like, I want to be an OT. Like, this is the coolest thing ever. This is an amazing job. It's a great schedule. The pay isn't bad either. I can probably do this forever. And that's kind of how I found OT.
And then the next question is, what does your day-to-day schedule look like? We'll start with what a typical physical and occupational therapist days look like, and then we'll dig in a little bit more because right now Jessica is the senior occupational therapist and a clinical lead role, and then I'm the senior physical therapist, also with a coordinating lead role. So those are a little different than the typical OT and PTs. For physical therapy, we do have a list of patients that we're assigned to. And in the inpatient setting, you might enter the office, get a list of patients that we're assigned to, whether it's on the computer or on the whiteboard. And then we have to do some chart review, figuring out what a patient had, what their medical history is. If they've had physical therapy or occupational therapy already established, we have to read up and get updated notes on that. And then we get to treat those patients. Usually a full physical therapy caseload could be 6 to 8 patients in a day, at least here at Shriners. And then we treat the patients. And then afterwards, we have to document everything that we did with that patient. And that's pretty much the flow. We might have time to document during the day in between patient care, or if we save it all towards the end of the day, then we'll have to do the charting at the end of the day. In between, there's emails and phone calls that we might answer to. It's just part of the job, or if we have to get in touch with the other team members, that can be really important too. A little bit different would be on the outpatient side of things, where you already have scheduled patients to see, and you know what times they start, where the patients are coming to you, and then you just get to wait in the gym and treat the patients when they arrive.
Yeah. So yeah, I'll kind of go over the same stuff. So depending on your OT setting, right, it could be completely different. So if you're at an OT outpatient sensory gym or sensory clinic, you might be seeing 2 kids an hour. And if you're in an 8-hour day, that might even be like, you know, around 16 patients. And every 30 minutes, you have a new patient coming in that is arriving. You're engaging them in some type of play that's therapeutic, depending on what you're working on. So that can look like from swinging on a swing to going down a slide to, you know, practicing some buttons. Here in the hospital, we have different service lines. So depending on which service line you're on, whether it's burns or inpatient or outpatient, your day will look a little bit different. I would say it's pretty fast paced. You have to be able to manage your own time. You're probably coming in, clocking in, opening up your laptop, going through the medical chart, and then from there you're off seeing patients. And then when you have time, documenting everything you do with those patients. And patient care can look like, I don't know, giving them a little stretch, from going outside and playing basketball with them to riding a bike around the hospital, which is really fun, or having them pull you on a scooter behind the bike in the hospital, or I don't know, maybe we decide to do a cooking activity. So it just varies, and every day is going to be a little bit different, and it's going to be fast, and you're going to come in, especially in a hospital setting, and you're going to blink and your day's going to be over.
Yeah.
Did I miss anything, Jeremy?
No, that was great. Now they know exactly what we do every day.
And we have fun.
Yeah. And then I won't go into too much detail, but in our lead roles now, we're involved with coordinating in terms of helping manage the schedule and deciding who's working for the day and who gets time off and things like that. But that's less fun than treating patients all day.
Yeah, and I would say most OTs and PTs typically geared towards the patient care side. So when you graduate.
All right. So the next question is, what was the most difficult part of your school journey to get to where you're at now?
Ooh, a difficult part of my school journey. I think for me, the most difficult part of my school journey in actuality was kind of taking that next step from undergrad to my master's program. In undergrad, I lived at home. I lived with my family. It was in state. And then that master's program, I moved to an island, which was amazing and fun. And also a little isolating and lonely because I didn't know anyone probably my entire first semester there. And you're kind of grinding in the books and studying and absorbing all the knowledge, and a little bit overwhelmed and still trying to learn how to adult and do your own thing and make friends in a new setting. So I think most difficult part is kind of that acclimating to a new school, acclimating to new friends in a new place, depending on where you're at, and kind of getting your mojo for your like daily routine and schedule.
And then for me, my most difficult time was that transition as well, pretty much graduating from undergrad. I did plan to take at least 1 year off. That turned into 2 years before I started physical therapy school, but just really figuring out how to strengthen my application, take prerequisite courses that I didn't have already completed before graduating from undergrad. And then also volunteering and working in those gap years, because the application to physical and probably occupational therapy schools is pretty intense. You have to gather a lot of like letters of recommendations, write your own personal essays, and yeah, just really make your application stand out as much as possible. So that was probably the hardest time.
On top of interviews, you might be traveling for your interviews. On top of, I know some interviews you do in-person writing prompts, like in the moment, which is nerve-wracking. So a lot of preparation.
Otherwise, once you get into PT and OT school, there is a lot of studying, and it is an intense program, but it's also a lot more fun because you're getting to do what your career is set out for. You get to really learn and practice hands-on skills and things like that. And then Sam, do we still have time to answer the other questions?
Yes, we can take one more question. Yeah.
Okay. Do you have a preference? There's two questions.
Oh, which one do we have? Just which one is next in line?
Okay. What kind of people tend to thrive in this profession? Yeah, pretty much anyone. You have to definitely have the mindset that you're committed and dedicated, because it is first of all intense schooling, and then once you start the profession, you do have to have interpersonal communication skills, being able to communicate not just to the patients and families, but the different team members that are involved. You have to be flexible because you might have a set schedule, but the number of patients that you see, if the patient cancels or no shows, or if there's a change in their plan on the day of, you might just have to be flexible and be able to work around and adapt to those needs. Anything else?
I think that's it, but I didn't choose PT because I don't like feet.
Yeah, and it depends on what setting you're in. You might be in an inpatient setting where you're seeing bodily fluids that you don't want to see, or on the outpatient side where you might treat hands and feet.
But yeah, and I would say, like, if you're kind of trying to figure out between which branch of therapy, definitely shadow all three in different settings, because that's a hard thing to figure out sometimes, because it's Venn diagram and you overlap so much.
All right. Well, thank you both for being on the call. We really appreciate it. It's a great overview, and I hope you have a wonderful rest of your afternoon and weekend.
Yeah, thank you for having us.
Thank you.
Good luck to everyone as you pursue your occupational and physical therapy careers. I'm just kidding. Whatever you pursue.
Bye-bye. Okay. So this concludes our session for today. We originally had a neurologist that was supposed to be on, but he had to reschedule, so you'll hear from him next week. But I am going to do a drawing for today, and the winner of the $5 card is Kennedy Hall. So I will go ahead and email you a $5 gift card. And so for those of you that are in person, you start your shadowing next week. You should have the information you need for your first day. If you don't, please send me an email. For those of you who are online students, we'll see you Monday at 10 a.m. and have a great weekend, everyone.